And next we move on to the award paper session. For chairing this session, may I invite Dr. Mahesh Karandkar and Professor Massimo Cardino. Can I give you some assignment to please chair the session? And third person could be Subodh Raju. Please chair the session. Dr. Subodh Raju is required on the stage for timing.
I can have somebody else. Are you sure?
I'm a bit tired.
Please go. Okay. Dr. Sahu, can you share the session? Okay, you will do the marking. PTR.
अरे आप सीनियर हो चलो चलो आप बैठो
Thank you. I'll see.
Our paper.
Actually, Ishwar has just landed. Let me give him some assignment. Please come and share the
Nice to be together. Hello.
Ishwar from Sri Chitra.
Oh, right. You are heading Sri Chitra now.
Right.
I know.
It's a 3 years of assignment.
start already late by 1 hour ऐसे तो कोई
Hello.
let's start the session and
We have award paper session now. So first speaker is Dr. Saurav Kumar. Is he here? The next speaker is Dr. Soumya T. Yes, she's here. So the paper is incidence of cervical spine injuries associated with maxillofacial trauma, a prospective observational study.
जिसको बोलना है आगे आ जाओ नहीं तो मार पड़ेगा start
Next PPT. Good evening everyone. Myself Dr. Soumya, postgraduate in oral and maxillofacial surgery. I am going to present my study done in our center regarding incidence of cervical spine injuries in maxillofacial trauma. Title of my study is Cervical Spine Injuries Associated with Maxillofacial Trauma, a Prospective Observational Study. As we all know, any trauma occurring above the level of clavicle, we should always raise a high suspicion for cervical spine injuries, especially any trauma to the facial skeleton. We should always assess, we should always include a specific assessment for this to rule out cervical spine injuries. Because any trauma to the facial skeleton, there is a chance of transmission of forces to the cervical spine injuries. So it's for a maxillofacial surgeon, it's always important to have a knowledge regarding cervical spine injuries, because if you are not recognizing any injury and we are trying to intervene in casualty or in OT, we are going to deteriorate the patient more. So it's always important to have to rule out cervical spine injuries and to have a neurosurgical consult. Aims of my study are to study the incidence of cervical spine injuries in a patients who sustained maxillofacial trauma, and to study the pattern of maxillofacial injuries, and also to compare the severity of the maxillofacial trauma and the cervical spine injuries. We have taken 270 diagnosed cases of maxillofacial trauma reported to the emergency department at BTGS Gulbarga, and we assessed for maxillofacial trauma, cervical spine injuries and also other injuries clinically and radiologically. All the patients underwent CT scan, which included series sections from cranium to the C7. Also further MRI was done for the patients, and we assessed for etiology of trauma, site of sustained maxillofacial fractures, facial injury, CVIT scale, cervical spine injuries and neurological deficiencies. And we have included all the patients who had maxillofacial injuries and belonging to all the age groups and all the genders, and we have excluded the patients who had age related degenerative changes of cervical spine. And our observations are like, out of 280 patients, we found 8 patients had cervical spine injuries. Most of the patients who attained the cervical spine injuries were in the mean age of 35 years, and most of the patients were male, and the most common etiology being road traffic accidents. And the most of the patients who sustained cervical spine injuries had mandible fractures, and the facial injury severity scale to be moderate. The patients who had cervical spine injuries, the trauma was in a moderate range, and among 8 patients, 6 patients had a neurological deficit. If we come to the intervention, the patients among 8 patients, 4 patients required cervical spine intervention for cervical spine injuries, and 7 patients required fixation for maxillofacial injuries. The fixation of maxillofacial injuries was done only after the fixation of after the intervention of cervical spine injuries and after a neurosurgical opinion and clearance for the surgery. And these are a few photographs of all the 8 patients who had both positive maxillofacial and cervical spine injuries. And it's very challenging for the maxillofacial surgeons to manage a patient with a maxillofacial trauma, because if you are going to manipulate a facial skeleton, however we want, without keeping knowledge of injury to the cervical spine, like there's always the transmission, there is a chance of transmission of forces from facial skeleton in the spine. So we might risk the patient, or we might increase the risk of patient being a neurological deficient. So it's always important to know the injury of the patient and manage proficiently. And in our study, our incidence is found to be 2.96%. If you go to the literature, incidence was ranging from 1.3% to 9%. This variation is due to study done in different population and different countries. And among the patient, 8 patients, most of the patients had mandible fractures, I could say, because the proximity of area to the cervical spine. And the majority of the cervical spine injuries occurred at the C6 and C7 level. And we could not draw any reliable conclusions regarding the correlation between maxillofacial fracture, type of site and CSF level, because a difference of force transmission. And both isolated and combined mandible fractures associated at all levels. And among 8 patients who sustained cervical spine injuries, most of the patients were in moderate facial severe injury. And when considering the managing a patient with cervical spine injuries, there is always we should always modify and manage the airway technique, and depending upon the neurological deficit caused by injury to cervical spine, specific changes have to be made in traditional method of management of maxillofacial trauma. I would like to conclude the incidence of cervical spine injuries with maxillofacial trauma in our study is 2.96%, and also I could say, based on our findings, as facial injury severity increases, chances of cervical spine injury also increases, and all the maxillofacial injuries should be examined for cervical spine injuries, and required investigations should be done clinically and radiologically, and very importantly, a multidisciplinary approach including neurosurgeons, maxillofacial surgeons and anesthetists is needed for optimal care. Thank you.
Any questions from the audience?
Clinical and radiological evaluation. What clinical evaluation are done in this case? You are not mentioned.
Yes.
Secondly, suppose there is cervical spinal cord injury as well as there is a maxillofacial injury, and both require surgery. Which one will do first?
So, obvious, first we have to intervene cervical spine only. So, because that is an emergency. If any patients who have cervical spine injuries with any cord injury, we have to operate it within 8 hours, or else we have to operate it early. So, first we have to stabilize spine, and then only our maxillofacial fixation should be done.
Why can't we do the same sitting? One sitting, one anesthesia, one surgery.
Sir.
Just maxillofacial plate and screw. What is their maxillofacial?
Sir,
No, see why I'm telling, when a neurosurgeon doing a major operation, 2 team can work.
yes.
So that brain surgery and this, because what you are doing, only instead of cleaning the skull, you are cleaning the face also. That's all. Because I had no concept of facial skeleton repair. I saw in a hospital acute head injury and the face repair going on together. Here the brain surgery, here the face surgery. Only thing, you clean the face.
What is the incidence of head injury in all these patients?
So we didn't assess head injury, sir, but there is a chance of, according to literature, 30% of chance is there, sir. Incidence is 30% maxillofacial injuries.
Clinical signs of facial injury, facial bone injuries.
Clinical signs means patient might present with pain on, like clinical examination, mobility.
You cannot have mobility of the facial injury.
Sir, mobility of the fragments, sir. Mobility of the fractured fragments, sir, which might displace and may cause airway obstruction.
Not this one.
Would you like to perform an CT or MRI or X-ray? Which one would you prefer for all these things?
Sir, actually,
Because that
we-
is what is going to impact the cost of the treatment, especially in a country like ours.
Yes, actually, if we take a CT, there's a chance, like in CT, we cannot, we cannot assess all the things in CT. The patients, like few things we might miss out in CT and we can see in MRI for especially cervical spinal.
Which one do you prefer?
No, your facial-maxillary
We prefer CT, sir. We prefer CT.
Okay. So not
For
there.
bone injuries,
And-
it is the best thing.
CT,
You
Facial CT scan.
have not mentioned that in your
Yes.
methodology.
Do you have any clinical criteria for assessment of cervical spine injury when dealing with a facial-maxillary trauma patient? Clinical criteria before
Yes.
you investigate further.
like first thing we would like to see for tenderness, cervical spine, sir. Then this neurological deficits, motor weakness and all will also aid to say that any injury to the cervical spine. All these things we consider. Thank you, sir.
Thank you very much.
Next presenter is Saurabh Kumar. Will present on safe balcony, a major contributor in pediatric head injury.
Okay.
Very good evening, respected delegates and my dear colleagues. I will be presenting on today's topic, that is fall from height, a major contributor to pediatric neurotrauma. So falls are the second leading cause of unintentional injury related death worldwide. Each year an estimated around 684,000 individuals die from fall globally, of which over 80% are in low and middle income countries. 37.3 million falls that are severe enough to require medical attention occur each year. In JPNTC, we noticed that fall from height is the common mechanism of injury in children with severe head injury. Aims and objective, study pattern, to study the pattern of injuries in children, regions of fall, severity of injury with fall, and the ultimate outcome that the child suffered due to this fall. The study design was prospective observational studies. Sample size was of 50, and the study was conducted at Jayaprakash Nayan Apex Trauma Center in Department of Neurosurgery. Duration of the study was from September 2022 to January 2023. Inclusion criteria was all pediatric neurotrauma patient from 0 to 18 years, and mode of trauma should be fall from a certain amount of height. So what we found out that throughout month, in the 5 months we analyzed, the green one is showing the number of cases which are coming from fall from certain amount of height. There is a huge difference between the case load that comes from, that is due to fall from certain amount of height and other mode of injury. Among other mode of injuries, we found that animal injuries suffered during playground in school and road traffic accidents. Now, age distribution, among fall, maximum amount of fall was seen in toddler age group 0 to 4 years of age. 33 cases out of 50 were in this age group, and other 14 were between 5 and 10 years, and then between 11 and 18 years of age. There was no sex discrimination between this male and females were equally enrolled, and we found out that the number and percentage.
Boys are more naughty.
Yes. And then height of fall. The height of fall had severe impact among the on the ultimate outcome of the patient. Among the all death that we analyzed, that was around 11 death in 50 cases that we enrolled. We found that those who suffered fall from more than 10 feet of height, among all the 11 death, 10 patients suffered fall from more than 10 feet of height. So height of fall had an significant impact upon the outcome of the patient. Now, place of the fall, since our hospital is located in Delhi NCR and being a government setup, we cater patients that come to us are mostly from the region. We found out that patient coming from Mewat had highest significance, highest in Mewat is in Haryana, sir, and then Faridabad, and then others. Among place of fall, maximum fall was from balcony. 50% of the cases were fall from balcony, then stairs, and then from roof. This is some of the real-time picture that we collected, and you can see this. There is no protective rails over the roof. Height of balcony is very low. This again is the real picture. Height of balcony is very low. Child, they have an inherent tendency to climb whatever they see. This was the unusual case of fall from stairs. You can see a low-income house with bricks and concrete, but there is no stairs. So they used to go in summers to their roof through this bamboo stairs. Ladder. And again you can see the height of balcony and protective railing that they have used. They have constructed a beautiful house, but this height is very low. Again this. The management of among this 50 cases that we enrolled, around 12 cases were managed operatively and 38 cases were managed non-operatively. Conservative management was done for this patient. An outcome, among 50 patients, 11 patients could not be revived and was declared dead, and 39 patients was discharged. Outcome versus height of fall. When height of fall is more than 10 feet, in our case, among 11 death, 10 death was the child who suffered fall from more than 10 feet. So the take-home message and from this was that there's simple 5 measures to make your home safe. First is put a net over the railing gaps. Second is verify if, the height of the protective railing. If it is not adequate, we should increase the height. And again, and the third point is that never put any furnitures or anything which can be used as a step ladder for the child in balcony. And balcony should never be used as a playground. And children, especially toddlers, should never be left unattended and unsupervised while playing. So fall from height is the most common mechanism of injury in children, and in order to prevent fall from balconies, supervision by parents should be increased. New laws regarding barrier of balcony should be enacted, and application of these controlled and campaigns, including public education and media attention, should be organized in our region. AIIMS took an initiative and we launched a Surakshit Chhajja and Surakshit Bachcha campaign to educate the masses regarding how severe it can be to their children. The simple 5 steps can have a huge impact in their family outcome. Again, on this Children's Day on 14th November, we observed Safe Balcony, Safe Child campaign, and with a tagline of "Put a net to prevent a death." Thank you.
Thank you, Saurav. I think this session is open to questions.
Why have to take only 50%? I have not understood what is the problem in number in AIIMS. No problem. The question is that little more effort can make 200 cases and make statistically significance.
Yes, sir.
If I spend 2 days to get 50 patients, I can spend 8 days to get 200 patients. What is happening? Beautiful study, but cannot be published. Like a beautiful girl cannot marry.
I think. More questions?
Is that correct?
Sir, okay. No, but this paper is important from a public health perspective.
But
We have.
exactly. See, what we want, you send a message that closed balcony is better than open balcony. Or the parents should not let the children to play alone in the balcony. That is the beauty. We segregate our children, no doubt.
So we are still enrolling the patient. Till now we have enrolled 50 patients and
Pediatry age group 10 years, 12 years or 18 years?
18 years we take. Because we had to compare other mode of injury also, because RTs and everything. so that we could show that fall from height is a significant contributor in pediatric neurotrauma.
No, one point, Saurav, is that, this is an important study from a public health perspective. We are going to give an important message to the public saying that be careful, take care of your children in balconies. But to bring in findings like the height of fall is directly associated with the severity of injury. This is not a conclusion for us
That is not a
to
conclusion,
make.
sir. We'll have to
Understand.
enlighten for yes.
I think even in this case, you would have taken 1 year retrospective study. It doesn't matter, prospective, retrospective, because you are not planning any prospective management. It is a study, studying the parameter which help you to analyze the outcome, right?
Yes, sir.
So retrospective would not help.
Yes, sir.
If you would have taken 1 year data of head injury trauma center, which is several thousand, it would have helped you. I am going to tell you, number is very, many conference I go, they say, this is a bigger study in this study. Who is going to do bigger study? Not even where?
We'll include, sir.
Even this Safe Balcony, Safe Child campaign, what exactly did you do and how did you execute that campaign? How many people did you reach?
Sir, with social media campaigning was launched, and our professors, they went in public and they had media interviews regarding the same on 24th
On
November.
that particular day?
On that report.
It's only 6
Tomorrow
months
the
now.
public
It
lecture
just
should be
started.
also issue. We have a public lecture tomorrow.
Yes,
So
sir.
for public who said, let not child be left alone in balcony which is not well protected.
Yes,
Be
sir.
careful when you send the balcony child himself to play. It is not the small children. If it's 2 years old, he can fall. It is the age group of 5 to 10, those are most mischievous. They can do everything wrong.
This location of Mewat, part of Delhi.
Yes, sir.
Is there any associated socioeconomic status of people there?
Sir,
Worried
mostly.
that children are, not left untouched.
So it is a suburban city with no regulations and everything. So mostly low and middle income people, workers. Mewat, sir.
Thank you.
Thank you.
Thank you.
अलग वर्ड में नहीं करा हमारा
Next presenter is Dr. Karthik. He will speak on predictive factors in pediatric head trauma.
Condition was fine, 3 maybe.
Confidence poor. 3.
Good evening, respected dignitaries, my senior faculty and colleagues. I am going to present a topic on predictive factors for outcome in pediatric head injury studied in our institution under the guidance of my professor and head of the department, Dr. Vijay Shekhar, and the co-authors are my assistant professors. Why we intended to make this study is that we observed a paradox that even though there is a dangerous mechanism of injury, children tolerate well. And the purpose of our study is to determine the early predictors of the mortality in a tertiary care center, Government General Hospital, Kakinada, Andhra Pradesh. And as this institute caters to a large number of rural population, and that we intended to study this also because the secondary insult is more important than the primary impact to the skull or the injury occurring to the head. And those are the hypoxia and hypotension, as well known major sources of secondary brain lesions, which can worsen the outcome if not they are not managed early, or they are given importance. This study is mainly done in pediatric head injury patients. All the patients who came to our emergency department from August 2022 to December 2022, and the materials we have taken and methods we have used is we have analyzed the following factors like age and gender of the child, mechanism of injury, and the history of symptoms of any raised ICP, and the vitals like pulse, BP, and oxygen saturation, and the clinical examination findings like pupil size, focal neurological deficit, and associated injuries. And the investigations mainly done are the CT brain and coagulopathy. And then GCS at the initial assessment and injury description, morbidity and in-hospital mortality are studied, as this was an in-hospital approach. So hypotension we have defined as blood pressure, 120 over 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / 100 / less than 5th percentile for that particular age, that is lasting for more than 5 minutes. And coagulopathy is INR greater than or equal to 1.5. And univariate we have done, and also the multivariate logistical regression was performed. And the results were taken as the factors which are statistically significant only. And the results we had are only we studied 43 injured population, but that was comparatively a notable cohort in our center, and the mean age was 9.6 to plus or minus 4.9 years. The youngest one is 4 months, and the elder was the 18 years, and the majority of age group is between 5 to 10 years. And 69% were males and females were 31%, a male preponderance was observed. And then head injury, that 89% cases are only having head injury and 11% cases are having polytrauma. These are the results showing that in patients who had morbidity, had more than 2 symptoms at presentation, history of 2 symptoms of raised intracranial pressure, and the children who died had all the 4. And these are some of the statistics, and the significant ones being the blood pressure and the hypoxia, which was taken as less than 90% on room air. And these are some of the CT scans of the injured children that we have treated. Our approach was, out of 43 patients we have studied, only 3 underwent surgery, but the majority 39 patients were managed conservatively, out of which 9% needed ICU admission, and the remaining patients were kept in the ward. And our outcome is the 4 children died, and morbidly means of any residual defects, and bedridden children were around 9, and other children, around 30 children were discharged without any morbidity and mortality. So the prognostic factors which are impacting the morbidity and mortality were studied in this study, and children more likely to survive than adults as suggested by our study if they are addressed very early. So some children some studies state that less than 5 years are having poorer prognosis, as also observed in our study. And Rivera et al. Also reported that boys have double the rate of brain injuries. We had also in our study the male preponderance, and we found out that the most common mechanism of injury was fall from height, but that singly didn't influence any neurological outcome, the mechanism of injury. And the initial GCS and GCS after 6 hours was also considered, which we observed independently also is a very important factor. Hypotension was a very important predictor along with hypoxia, and coagulopathy had a significant higher mortality. And the polytrauma not significantly associated, only the pneumothorax was seen associated with the morbidity and mortality. So in this study what we have concluded is the fall from height being the most common mode, and outcome can be anticipated in the early phase only with simple clinical data like hypotension and oxygen saturation. Low GCS, initial hypotension, hypoxia, presence of coagulopathy and young age can determine the outcome. Thank you, sir.
Nice paper, I think good study. Paper open for discussion, sir. Mahapatra, sir.
What you have told, what is not known, is known for like the age of the patient, nature of
Everything,
injury. What is
is-
unknown?
it is
What
n-
is new in this?
Not a new one, sir. Actually, in our center, which is only like a tertiary care center of a district where resource limitation is there, we thought of assessing the predicting the outcome with only simple clinical data, sir. Means assessment of the child clinically.
No, that's
So
all right.
initially-
What is new?
No, sir, what is lacking in our country is
What is
studies
lacking?
from our population.
What
We
is
always
lacking?
depend on the
Okay, let me say what is lacking.
white man statistics for everything.
Right? Why only 40 cases? There is no accident in Andhra Pradesh and Canada. See, I asked our AIMS person also, same thing.
So we
But
have
if you take a bigger series, your chance of having statistical significant result is good. You will not, I am sure that you will not, if paper comes to me, I will not accept. I say, India में का बच्चे का मरूडी है क्या? Feminine of the children?
Sir, according to our intake, in the 5 months, we are able to study 43 cases, sir.
Take 1 year.
Yes.
Take that 1 year. Doesn't matter. Here in this study,
Dr. Karthik, one question. You have said hypoxia and hypotension. How did you assess that in your clinical setting?
So hypotension, we have measured the blood pressure, sir, and for that age less than 50th percentile was considered as hypotension, sir. And,
Was it with an arterial line or is it with the cuff measurements?
Is only cuff measurement, sir.
Fine,
And
yeah.
saturation was recorded with the hand probe, sir, which was considered less than 90%.
So this was one recording or several recordings?
On recording at the time of admission, sir.
That time of time. The second question is, you have made in the discussion a comment that outcomes are better than in adult patients, pediatric this thing. Was the study intended to compare the results between the two? Because that was not one of the objectives of the study.
Yes, sir, that was not one of the objectives, but we have observed that while doing this.
So when you do a study, focus on what you're doing.
Yes.
Don't compare with things which you not mentioned in the objectives. Anyway, very good paper from your part.
Thank you.
Next speaker is Dr. Srijit.
4 for content. Confidence poor, not good. Timing is good.
I'll start.
Yeah, please.
Good afternoon, everyone. My topic is role of expansion cranioplasty following decompression craniectomy. Decompression craniectomy with neuroplasty has been the gold standard for refractory intracranial hypertension for a while. There are several morbidities, however, associated with decompression craniectomy, of which the persistence of bony defect is of paramount importance. Studies have shown that many of the associated morbidities get reversed following replacement of the bone flap. Complications and morbidities are divided into early and late. Early include hematoma expansion, external cerebral herniation, wound complications, CSF leak, postoperative infection and seizures. Delayed or late complications include a subdural hygroma, hydrocephalus and syndrome of the Treffield. Hence, we perform a technique of expansion cranioplasty, which is mainly aimed at avoiding a second surgery of revision cranioplasty and thus helps in reducing the economic burden as well as in preventing the morbidity of the bone defect. Materials and Methods is a prospective comparative observational study at Department of Neurosurgery JJH from Jan 2017 to May 2022. Total patients included were 67 who underwent an expansion and 110 who underwent a decompression. Following parameters were analyzed: the demographic features, the operating time, radiographic variables such as change in midline shift and expansion of the compressed brain, both ipsilateral and the contralateral side, and an ICP monitoring was done pre-operative and post-operatively. The selection criteria: patients included were those of the age 12 to 65 with a GCS of 4 to 8, serial CT of the head showing features of raised ICP and a midline shift of more than 5 mm, a fall in GCS of 2 or more points from the time of initial presentation. Exclusion criteria were patients of GCS 3, bilateral fixed dilated pupils, severe coagulopathy, signs of brainstem involvement, penetrating brain injury and a compound skull bone fracture, and malignant brain swelling. The surgical technique: the ICP was measured before expansion cranioplasty. A borehole craniotomy was done. You can see the borehole is done at Cocker's point, and then using a brain needle, the dura is punctured, a trocar is inserted, and a small ICP probe is inserted to measure the ICP before the process of expansion cranioplasty is started. You can see the ICP probe being inserted. After that, patient is put in supine position with head turned to the opposite side, head end elevated. Skin incision is that of a big FTP craniectomy incision. The bone flap removal is similar to that of a DC flap removal with the portion of the bone flap removed. Temporal craniotomy is extended up to the floor of the middle cranial fossa up to the level of the zygomatic arch. We use a silicone patty below the dural cutting to avoid injury to the tense brain. However, you can see if after making a nick in the dura, a silicone patty is inserted and the dura is cut above that. The dura is opened in a C shape with radial cuts if required. Following that is the most important step of expansion cranioplasty. The bone flap is then divided into pieces after cutting it with a cutter. Each bone piece is loosely sutured to the other piece as well as to the pericranium on one side of the calvarium with ethylon sutures. As the brain expands, the bone flap floats out in all 4 directions, giving space to the expanding brain, thereby reducing the ICP. This is how it looks like at the end of the procedure. The ICP is noted during the closure at the end of the procedure. These are some examples of acute SDH, preoperative and postoperative for frontal contusion, an MCA infarct. Analysis: both preoperative and postoperative CT scans were reviewed. The change in midline shift and percentage of brain expansion on ipsilateral and contralateral side was studied. The demographic features, male 67, male 49 and 18 undergoing expansion, and for decompression male 87, female 23. Mean operating time for expansion was 186 minutes and for decompression was 178. The change in midline shift percentage for expansion cranioplasty was 49.2% and for a decompression was 58.7%. Percentage change in ipsilateral brain width was 16.2% and 14.4% for expansion and decompression respectively, and a percentage change in contralateral brain width was 37% for expansion and 28% for decompression. Cosmetic comparison, these are some images. The advantages: an early cranioplasty had a better functional outcome. Second, it's cost effective. Patient saved 60 to 70,000 the cost of an implant. It prevented the physiological and psychological morbidity of a bone defect, provided a good cosmesis, reduced the vulnerability of the underlying brain. The syndrome of Treffind is avoided and patient avoided a second surgery. The syndrome of Treffind is basically a sinking flap syndrome, which is a delayed complication, which is associated with headache, dizziness, irritability. The proposed mechanism is that since there is no bony support, atmospheric pressure is directly transferred onto the surface of the brain. Neurological worsening has been described after decompression craniectomy, with improvement occurring following institution of a cranioplasty. Expansion cranioplasty thus prevents the syndrome of the Treffind as the bone flap gradually returns back to its normal position along with the regressing brain. There are some disadvantages that the procedure cannot be performed in patients who have malignant brain edema and in patients who have a compound fracture and contaminated wounds. The discussion: the management of intracranial hypertension is of a greatest challenge for a neurosurgeon, with approximately 10 to 15% of cases the treatment being refractory to medical management. Here a decompression is a life-saving procedure. However, decompression in itself is associated with a varied spectrum of complications, as I mentioned before. With regard to the timing of cranioplasty, studies have shown that patients with an early cranioplasty had a better functional outcome. To conclude, expansion cranioplasty is as effective as a decompression craniectomy technique in the surgical management of refractory intracranial hypertension. The major advantage of this procedure was that it avoided a second surgery of a revision cranioplasty. An expansion cranioplasty also avoided the economic burden of a second surgery and the psychological morbidity due to the presence of a large bony defect. It avoided the syndrome of the Treffind. Expansion cranioplasty deals with the issue of expansion of the effaced brain on the side of decompression, along with dealing effectively with the midline shift, which makes the study more relevant. Thank you.
Nice study. Paper.
So for 3 days, sir.
And was there failure where you have found that the ICP is rising and you have to remove the flap in some of the cases?
Sir, in our study, so far we have not found that. There was just one complication that happened, that there was a wound infection which was unrelated to this. We did not find a scenario where the ICP had gone up and we had to remove the expansion cranioplasty bone.
You did the cranial volume estimation?
Pardon, sir?
Cranial volume. You say expansive cranioplasty.
Yes, sir.
Expansive means the cranial volume expanded. So did you do a volumetric analysis? See, if I say I have done an expansive cranioplasty, that means the intracranial volume has gone up.
Sir, we calculated the midline shift and that somehow showed.
No. See, the question is, you know how to calculate the skull volume.
Yes, sir.
Intracranial volume.
Yes,
if
sir.
you know that, so what you done basically, instead of only doing this, you have put a duroplasty.
Yes, sir.
So that the brain can expand.
Yes, sir.
Tight dura will not allow, if despite of cranioplasty, tight dura will not allow brain to expand.
Yes, sir.
So that is the reason you are talking about only craniotomy or craniotomy and duroplasty.
Yes, sir.
So it is not called expansive craniotomy.
Okay, sir.
So it is not, see, you can choose your own terminology, expansive. I will tell that when I do a small head to large head, then this is expansive.
Understood, sir. Yes, sir.
And did you have any study?
Not expanded.
Sir, actually,
Expense side should be the correct word, I think.
we are just differences over the
Yes, sir.
work,
Yes.
nothing more than that. It does not take away the worth of the study.
Yes, sir.
But what you want to know is, has any study been published in this,
Yes.
on this front?
We had a thesis about 7 years back doing only craniotomy and duroplasty. And still compressed by tight dura. Because dura is very tough structure, right? So what you are telling, if you are doing decompressive therapy, also do a dura.
So we are cutting the dura in this, sir. We are not doing a duroplasty. We just
Leaving the dura open.
we do the standard decompression craniotomy, open the dura and put a bone flap on top after cutting it in pieces.
Dura left open.
Yes, sir.
No, that is not accepted any standard. You know why? That will definitely call CSF fluid, CSF collection. If you
Sir, we do a lax duroplasty. We put patty and we put glue and we put.
dura open, you are putting a dura plastic.
Yes, sir.
So why the dura open? Long-term outcome.
Did you compare the cognitive the differences between the two?
The outcomes were similar, sir. There were no cognitive differences.
There are a lot of paper, they say that you save life and create vegetative state and severe disability. If you are doing to save life, you achieve a result. So the decompressive craniotomy with a duroplasty save life. But if you put a 6 month analysis, 1 year analysis today, there are more survival with severe disabled state or vegetative state.
So those outcomes were fairly similar. The only difference and the advantage of this is that patient does not have to undergo second surgery. Patient avoids the cost of an implant and the morbidity of having a persistent bony defect. Rest everything is.
Your focus is the cost of implant and the second surgery, correct?
And
Not
the
the cognitive
and
and
the avoidance of the morbidity of a bone defect. The cognition more or less remains the same. There is no difference. Sir.
Yeah, this study is relevant because, in a country like ours, again, cost factors.
Yes, sir. Yes, sir.
Because a second surgery is definitely
Yes,
preferred.
sir. Correct.
But the question is, does it have the disadvantage over decompressive craniectomy? That was the question. That's all. It's not about the results of decompressive craniectomy. Sir.
So that is
So in that way,
So the results of decompression is the same.
You
yeah.
did a thesis from this institute 2007 and 8. I was in Sanjay Gandhi. I read that paper. I have quoted that paper several times. It only increased the number of survival patients, but ultimate outcome of vegetative patients or severe disabled high. So death to survival. Today morning we are hearing that. Yes. One of the paper. Yes.
So we are doing a decompression to reduce the ICP. The outcome for that versus an expansion is the same as far as the ICP reduction is concerned.
You study 6 month outcome, 1 year outcome, 2 year outcome?
No, sir.
It's only immediate outcome.
It's only the decompression part of it, the part where we operate to reduce the ICP, that is the same for both the procedures. The additional advantage is that the cost factor, the morbidity and the cosmesis part, that's the additional advantage. Rest everything else is the same that of a standard decompression.
you have a publication from India.
It's
on this
it's
one. Where is it?
it's in the pipeline, sir.
No, you already have, there is already a publication on this one, what you call it, a floating cranium.
Yes, sir.
this
Yes,
thing.
sir.
If you read the
It has come in Neurology India.
Okay, sir. I'll read.
last book we have published 2020. Head injury. It's about 900 pages.
Yes, sir.
It is that all as a reference of decompression.
Yes, sir. Okay.
That's only a term. We are fighting Kipling over.
Right, thank you.
Thank you, sir.
Thank you, Dr.
Should not take away the credit.
Next speaker is Dr. Anil Kumar. He will speak on epidemiology of pediatric head injury.
Sir, good evening, delegates. Good evening, judge.
Just a minute.
Okay, sir.
Fine.
Sir, before starting my topic, let me introduce myself. My name is Dr. Anil. I am a second year neurosurgery resident from Rangarai Medical College, Kakinada. It's yes, sir. I have this is a topic regarding epidemiology of the pediatric traumatic brain injury cases. We analyzed based on the abbreviated injury score and GCS scores. So, basic introduction: the trauma has been become a leading cause of mortality and morbidity in India. Although the children and adults have affected the traumatic injuries, the problems are worse in the pediatric age group due to the long-term complications of morbidity and mortality. So, the measurable deficits usually even occur with a mild, moderate, and severe traumatic injury, markedly greater after the severe injury. In addition, the presence of intracranial injury contributes significantly to mortality resulting from the polytrauma. And traumatic brain injury, the case fatality rate usually ranges from less than 1 to 40%. And I just wanted to mention about the numbers, like last year in US around 50,000 deaths were happened, and in India that number of deaths has been increasing to 4 lakhs according to the data presented in 2021. So we need to be more cautious because in Western countries the preventive measures are being taken very seriously. So we need to increase to reduce the incidence of the traumatic brain injury. So just wanted to mention about the abbreviated injury scale. This scale has been introduced in the 1969, and this scores ranges from 1 to 6. The AIS 1 is minor. That means if patient has headache, dizziness, and there is no loss of consciousness will be there. Whereas moderate AIS2 is loss of consciousness for less than 1 hour, and AIS3 is loss of consciousness for 1 to 6 hours, and 4 is for more than 6 hours to 24 hours, and whereas AIS5 is more than 24 hours of the loss of consciousness will be there, sir. So this has been published earlier at Brandon P. Foreman et al. in the year 2007. So the material methods, it's a retrospective cohort study of 52 patients were considered under less than 18 years of age from the period of June 2022 to January 2023. So all the patients who were admitted in a trauma has been collected, I mean the data collected from the trauma registry. Using the GCS and AIS, we evaluated all the cases. So out of 52 cases, 46 cases that were managed conservatively, and among them 6 were operated, out of which 4 were operated for depressed fractures and 2 were for EDH, extradural hematoma. But for statistical analysis, Shapiro's Wilk formulas and histograms were also used, and based on SPSS statistics software formula, we have derived results. So I just wanted to focus that we have found that there are history of falls are more common than the history of RTS. So among history of falls, among total 52 cases, 41 cases were males and 11 were females, and among them falls were more common than RTS. Falls cases were about 32 cases were there. Among them, most predisposed age group is 4 to 8 years of age group. People are having more instances of falls, and among RTS, about 20 cases, among them 13 to 18 years cases were there. Among them, 9 cases were dominant, sir. These are the cases where children used to go on bike without the knowledge of the parents. So those cases were most common, sir. So we have evaluated both the AS and GCS scores. Because of this was the distribution of the male preponderance was there. History of fall was more. And after combination of these two, so we have tried to analyze whether AIS and GCS can be better outcome. So we found that because of the number of cases were less and duration is also small, so both of the factors were not that significant. But what we found is the combination of AIS and GCS can give a better outcome than a single status alone. So as GCS and AS are weakly correlated with this 7-month period duration, earlier Demetrius et al. also had same study of 7,764 patients to assess the prognostic value and limitations of the GCS as well as had a AI score. So the thing is, we need to safety measures. We need to take some safety measures like blood alcohol concentration limits. People who are school going without the knowledge of the parents, and the other one is using of seat belts in the children, and along with wearing a helmet while cycling. So the major difference between Western our countries is just the awareness and the safety measures are the differing factors where we can this thing. In conclusion, there has been a recent change in the epidemiology of TBI among children. They have shifted to increased number of cases from younger age group. So most of the cases were between moderate to severe, that is severe TBI, were falls followed by RTS. So falls were very frequent than RTS. So it is suggesting the importance of the preventive measures to decrease the morbidity and mortality by TBI. So though the pediatric traumatic brain injuries are not common, so yet found that the TBI of pediatric age group are most commonly due to falls, followed by due to reckless driving of the bikes, especially in the pediatric age group of 10 to 12 standard pupils. Thank you. Thank you, sir.
Sir, paper open.
You told very interesting. 2 to 4 lakh people died in India every year, right? 2 to 4 lakhs?
No, sir. 4 lakhs in the period of 2021, sir.
No, it is between 1.7 to 1.8 lakh people die. Because yesterday night only I was reading after dinner, how many people, because you are doing a head injury conference, we should know how many people are dying in India.
Yes.
So actually you don't give, and if you take the pediatrics, you told here there, pediatric head injury poor prognosis. No.
Yes.
Pediatric head injury broken to below 2 years, 2 to 10 years, 10 years above. Because 2 years below, when you intubate them, the laryngeal edema, the small, very big tonsils, adenoids, the passage is different. So intubation and ventilation dangerous in a child below 2 years. So that is not the same a child above 10 years.
Yes.
So that is the reason why McLaurin say a small child is not an infant or child is not a small adult. So they have physiology which is different for 2 years, 2 to 5 years, 5 years above. So that McLaurin 1960s say child is not a small adult. Okay, so that is the reason we have to understand physiology of a child. Their head is bigger than the body surface.
Yes.
So, again a small sample size of 46 cases, small duration of 6 months. So,
Did you understand they are from same place?
yeah.
They have taken the same data.
Same data,
So,
same.
what is the take-home message out of this paper?
Sir,
What
we-
were you trying to, what
No,
were
sir,
you
we
trying
just
to
wanted to
Correlate and what
correlate
led to your
the-
final decision?
Sir, we wanted to correlate the severity of the head injuries with the AIS and GCS.
So do you think it
combination.
works?
That's what we want to try, looking for, sir.
So did you find it positively or
Because
not?
of this small sample size, we couldn't evaluate, but further we'll study the same
You wish
and
to do it
we'll
further.
get, yes, sir.
I'm happy that Emperor Medical College is represented here. I
Yes,
think
sir,
Shankar
that
is pushing his residents to come here and do it.
That's very nice.
Yeah. We are getting data from all those parts of care.
Yes, sir.
So far remain quiet.
Yes.
Thank you.
Thank you,
Thank
sir.
you, Dr. Anil.
Thank you, sir.
Next speaker is Dr. Hemant. Will be presenting on spinal alignment in traumatic spine injury.
Hey, all of you are in OT dress. Why?
Coming from OT.
They are so heavy worker.
Good.
Nagana dress.
Good evening, respected delegates. So my topic is spinal alignment after fixation in thoracolumbar traumatic fractures, and it is just an interim analysis. At the onset, I just wanted to tell. So usually the major cause of traumatic spine injury, as we have seen in other presentations, also that falls more than RTA, and most commonly at the thoracolumbar levels. Usually we do posterior fixation as per the TLX score, and the goal of fixation is for restoration of spinal alignment and cord decompression. Sorry, sir. So the rationale for the study is that sagittal balance is necessary for a stable and compensated posture for all of us, and this involves interaction of cervical, thoracic and pelvic parameters as a whole. Now correlation of functional outcomes with these parameters is present and quite well known in cases of listhesis, scoliosis and deformity correction. But in traumatic spinal fractures, it is slightly scarce as compared to the others. So the methods of the study was, it is a prospective observational study, and till now the sample size is 10, and people with any vertebral fracture with ASIA impairment D or E were taken, and who underwent instrumentation for the same. We would do pre-op whole spine x-rays in the supine position, and 3 months post-op standing whole spine x-rays. Now the parameters that were checked were epidemiological, age, sex, mechanism of trauma, operative parameters like how many segments were fixed, levels of fixation, blood loss and technique used, and radiological involving the angles measured like the kyphotic angle, thoracolumbar junction angle, pelvic incidence, pelvic tilt and sacral slope, and other lordotic measurements. So the results of the study, the mean age was for 45 years with a follow-up of 3 months, and there were 9 males and 1 female. 6 were RTA and 4 were fall from height, and 6 ASIA E and 4 ASIA D statuses, with levels of fractures being at D12, L1, L2 and L3 as shown. So operative parameters, so these were operated both by minimally invasive techniques and open techniques. 6 were via percutaneous fixation and 4 via the open technique. And the blood loss was 50 ml and 200 ml, and number of levels fixed were 2.2 and 2.8, along with the duration of surgeries correspondingly. And the radiological parameters that were measured at pre-op and post-op statuses are as shown. And these were just some of the whole spine X-rays that were taken. So the conclusions from this interim analysis was that only the regional kyphotic angle was changed from pre-op to post-op, and any other radiological indicators showed no significant changes. And although not statistically significant, was that minimally invasive surgeries obviously had lesser time and blood loss. Now coming to discussion is that whether sagittal balance influences any clinical outcomes post fixation for fractures, and studies have shown that there is a positive correlation. And the implication of this for a surgical technique is, can it change our technique? Patients with residual kyphotic deformities can lead to persistent pain. So knowing how much ideally we need to correct for any fracture should be tailored as per the patient. And some of the problems include that for patients with fractures, checking global spine imbalance preoperatively is difficult because they won't be able to stand. And when we do an analysis of minimally invasive techniques, due to lesser dissection, will there be better postoperative sagittal balance? So the demerits of this study is that it is obviously a very short follow-up, and we are doing a supine versus standing.
Can there be silence in this auditorium, please? People in the back. Sorry.
And obviously we are comparing supine versus standing, and because of the small sample size, subgroup analysis between minimally invasive and open is will not be possible, and again clinico-radiological correlation is not possible. And because we are also not even randomizing whether they undergo minimally invasive or open techniques. So that is it. Thank you, sir. So that was both minimally invasive done. Yes, sir.
One had four
level fixation.
You did 4 level.
Yes, sir, 4 level minimally.
So, but here you're not comparing you're only comparing the
Yes, sir, it is just the alignment.
Alignment.
Yes, sir. I just, the objective of the study was not for...
Not the clinical
yes,
improvement or not.
Actually, it was short duration, sir. So,
Again, why 10 cases?
sir,
I have been working with trauma
No, sir.
for many years.
Yes, sir.
Trauma center, we say we admit 30,000 cases.
Yes, sir.
3 lakhs of trauma patients and present 5 cases.
Sir, one issue is pre-op X-rays, whole spine won't be there, sir. Whole spine X-rays we don't do, sir. CT will be there. From the CT, the whole spine X-rays. Yes, sir. For these cases, I am getting it done, sir. Yes, sir. Yes, sir.
Observational study, all the parameters will not be helpful.
Yes, sir.
Because then only that we can do.
Yes, sir. Thanks.
So I would like to conclude this session, and the results of this winners will be declared tomorrow evening after final session.
Why wait for tomorrow? We can do it today also if you want. Why wait for tomorrow? Yeah, tomorrow.
Yes, sir.
Come, you are the person judge. Let's see if both of us correspond. Yes? Sir is the third umpire, or the fourth, the third umpire.
Thank you. We close